Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and we are once again drawing a little bit of audio from the Only in Staten podcast, the one that I work on over at my job in Staten Island University Hospital. I got to sit down with our director of interventional cardiology, the director of the catheterization lab over here, Dr. Ruben Kandov, to talk about some of the things around ACS that are not STEMI. We mentioned a little bit about STEMI, but really our focus here is on the patients without STEMI with ACS that we are concerned and what medications we should be using, indications for consultation and for the cath lab. I think it's a really good review, and that's why we are going to co-publish here so that everyone can get a listen. Welcome to the podcast, Ruben.
Thank you. Thank you for having me. Excited.
This is going to be some real bread and butter information for you, but really good to get out to the emergency medicine world. Chest pain is such a common chief complaint in the emergency department. I think it is the number 2 or number 3 most common thing that we see. And the really easy ones are the STEMIs. The honest truth is, you look at the ECG, it shows a STEMI, you activate a STEMI code, and the patient gets whisked away. It's almost the easiest patient for us to deal with in a center that has a cardiac catheterization lab on site. It's actually the non-STEMI cases that are much trickier to manage and have a lot more nuance. And that's what I really want to get into. I'm hoping that you can help us to really focus down on how we can take best care of that group of patients. Sound good to you?
Yes, sure.
All right, so let's start with some of the common medications, the medications that we know are indicated when we are concerned about ACS. And probably the most common one that we use is aspirin. Every patient where we are concerned about ACS should get an aspirin. What's the real benefit here? And does the exact dose that we give matter?
The data on aspirin benefits in ACS is probably some of the trials were done before I was born. And, the rapid platelet inhibition with especially chewable aspirin, you get your effect within 20 minutes to a half hour. For patients that are aspirin naive, 4 baby aspirins to chew or full dose aspirin, whichever way you want to give it. For patients that have been already on aspirin or been on long-term dual, let's say antiplatelet therapy, some of us reload, some of us just continue what they were already on. There's no harm ever giving somebody couple extra baby aspirins in emergency room to chew, because again, the added effect of antiplatelet inhibition is a big deal in all of the ACS patients.
So aspirin is going to be our go-to every time. I think that if I remember correctly, those old studies from the early 80s showed something like a number needed to treat of around 16 to 20, which in medicine is virtually unheard of. A medication where
Correct.
For every 20 patients, I save a life, and it's dirt cheap with very little harm. Really pretty incredible.
It has to be, it's a must drug for all ACS patients, and it's a must drug to start as early as possible. A lot of our patients are going to be given aspirin by EMS. Some of the walk-ins or drive-ins themselves, if they don't know about it, obviously in emergency room, they must be loaded with aspirin.
Okay, so that's the easy one. That is the must do in patients. And if you are concerned about ACS, you give an aspirin, it ends up not being ACS, you probably haven't done much harm. So it's really why we should be widely distributing aspirin. All right, so we're in agreement on that one. Let's move to some of the other medications. Nitro is another one that we love in the emergency department. Again, we know if patients have cardiac sounding chest pain, we should give them nitro as long as their pressure isn't already soft. And this is going to be a little bit of edging towards that STEMI patient. Is it important, once I've recognized that the patient has a STEMI, they're going to the cath lab, is it important for me to give them nitroglycerin to help to relieve the discomfort of that STEMI, or is it really lacking of any benefit at that point?
It actually, there's no mortality benefit with nitro, whether it's a long-term use in outpatient settings or use in acute settings with IV nitroglycerin, there's no mortality benefit. But in selected patient population, especially the ACS patients that are present with hypertensive urgencies or on the hypertensive side with their blood pressure, nitro has a great role. First of all, it helps with chest pain and kind of reduces the preload. So in those patients that are borderline kind of going towards the developing shock and things like that, when the pressure is still high, nitro will have a great preload reduction as well. It lowers their blood pressure, which a lot of the times helps those patients as well. So individual care. Obviously, we don't do nitro in inferior wall MIs. You'll create a major, major problem, even if they hypertensive on presentation. Once you see inferior wall MI or you suspect RCA territory infarct, please stay away, or dominant circ for that reason. Stay away from nitro.
So nitro does really still have a benefit here, make the patient a little bit more comfortable. That vasodilation, giving that preload reduction is going to be beneficial. And I love that you kind of edge towards, again, that hypertensive emergency where the patient's having chest pain, and nitro should be our go-to drug there to reduce that blood pressure, reduce that strain on the left ventricle. Let's talk about some other antiplatelet agents. We already talked about aspirin. We are pretty much fully embracing the dual antiplatelet therapy model. And there's a number of different drugs here, trade names like Brilinta and Effient and Plavix, and the non-trade names, which are fairly unpronounceable, ticagrelor, Presergil, and clopidogrel. These are the agents that we're commonly seeing. And Ruben, I'll be honest, I've worked in a couple of different places. Some places I go, they are absolutely adamant that ticagrelor is the drug. Other places are like, nah, clopidogrel is just fine. Which of these medications should we be reaching for? And are they an all-comer? In all-comers that we are worried about ACS, should we be reaching for these P2Y12 blockers?
Great question. And there's a lot of controversy with that. Like you said, I mean, it varies center by center. It varies by protocols. STEMI patients will load. Everybody's in agreement. And, Brilinta is the drug of choice because of, again, benefit shown over Plavix with that patient population. So, if we have Brilinta, it's available, use it. I must warn you that, we have a lot of smokers on the island, COPD patients with asthma. Those patients usually don't do well with Brilinta, and they start experiencing symptoms of shortness of breath, as they call breathlessness, probably within half hour to 45 minutes after the drug load. It's hard to predict who's going to develop it, who's not. I'll tell you about probably 20% of patients develop the side effect, and it could potentially be problematic in the post-procedural area because, someone's short of breath, you start asking yourself, are they going into CHF? Did I create something? Or is this just Brilinta effect or something else going on? So a little caution with that patient population, but yes, Brilinta is clear evidence over Plavix. We do not use Effient as a preload in the emergency room because the way Effient was studied, and it's the most potent antiplatelet. You get over 60% of platelet inhibition within the first half hour after you load. And for those unfortunate patients that will have triple vessel disease and will need emergent surgical interventions, it will create a major, major problem. The surgeons will hate you. It's a major, major issue with that. So don't load Effient. We do Effient loading in the cath lab once we see the anatomy. And Effient is more, kind of for younger patients, patients that, once a day medication is preferred and things like that. There's certain caveat with the Effient as well. But again, very strong antiplatelet, high risk of bleeding. We do not want to use it in emergency room. That's the STEMI population.
Yeah, so in those STEMI patients, if they tell you, oh, I smoked 2 packs a day for the last 40 years, would you go with clopidogrel over ticagrelor in that patient group? Or you just kind of keep it in the back of your mind?
I would strongly consider it, especially, let's say, if you see that they on bronchodilators, inhalers, and some medications for COPD, asthma, and things like that. I would consider it because, yes, again, there's benefit, mortality benefit with the Brilinta over Plavix, but it will create a major issue symptom-wise. Patients will hate you. The cath lab, everybody get excited over this stuff. So I would be careful. I would strongly put into my consideration before loading those patients with Brilinta.
All right, let's talk about the non-STEMI patients. And we're jumping a little bit ahead, but I don't think we're going to just give one of these agents if the patient is just in suspicion for having ACS. But let's say that we get a troponin back and it's positive, they have some ECG changes. Should we be loading them with one of these agents as an antiplatelet, or should we wait until we talk to our cardiology colleagues about that?
So believe it or not, the greatest benefit of a second antiplatelet or dual antiplatelet therapy in this patient population, and if you think about it, STEMI patients, like you said, they spend 10-15 minutes in emergency room, they get taken up, they get revascularized within 30 to another 40 minutes, and mechanical revascularization plays a major role in how well they do in the future. With those high-risk unstable anginas, non-STEMI patients, some of them, it will take 24, 48 hours before they end up in the cath lab. And withholding medical therapy in this patient population creates, unfortunately, some issues and problems. So what I usually, the way that the thought process or the teaching with our fellows or our ancillary stuff is, if you see somebody who's having an MI, it may not be necessarily in ST elevation MI, but you see patients uncomfortable, they have recurrent chest pain, the EKG changes with ST depressions or whatever ST elevation AVR, and you suspecting that this might be a triple vessel disease based on EKG, and the most common one, elevation in AVR and diffuse ST depressions. Those should be I would suggest getting in touch with cardiology immediately, and those would benefit from early, at least invasive strategy where they come up to the cath lab for an early cath. Those patients, you could probably withhold antiplatelets. In younger patient population, in patients that we think low risk of triple vessel disease, let's say non-diabetics, I would load antiplatelets, and Plavix a lot of times will do the trick. Once they come up to the cath lab and they get studied, and a lot of them will get switched either to FN or Brilinta based on their lesion and demographics and risk profile and things like that. But in a lot of those cases in emergency room, Plavix should be okay.
That's some really good information there. I just want to restate some of those things. So if you have the patient with that AVR elevation, the ST depressions that are a little diffuse, that patient probably has triple vessel disease, and we want to edge away from these medications and closer towards early revascularization or early catheterization at least, because you don't want that extra antiplatelet on board to piss off your cardiothoracic surgeons if the patient needs to go for a CABG. But in the younger patient where they have a non-STEMI, they are less likely to have triple vessel disease. These medications can play a really important role, especially because catheterization is going to be more delayed in that non-STEMI population. Those are some really great tips. And I think it makes sense then of why we get this advice of who our cardiologists tell us, please load this person, don't load this person. That helps us to, I think, make sense of a lot of those things. So let's say that I have one of these patients, either it's a STEMI or it's a non-STEMI with positive troponin, some ECG changes. They're going to go to the cardiac catheterization lab. What are some of the things that we want to do for that patient before they get whisked away in the emergency department?
So medical therapy is important as, the early invasive strategy. So, IV heparin, at least the bolus with a lot of those patients should be done. And remember, 60 to 70% of our cases are radial. So this doesn't affect bleeding. Doesn't create any adverse outcomes for us. For patients, especially that, let's say, a transfer from south or someone who's here but not going to be going to the cath lab right away, if they hypertensive, active pain, IV nitroglycerin. If they, normotensive, still having pain, IV heparin, whether the bolus and then followed by infusion. Dual antiplatelet therapy in the right patient population. Early statins is a big deal. I mean, there's actually data that shows you that if you load somebody or give high dose the statin before they even go to the cath lab, those will make a difference on the long-term outcome and prognosis on those patients. So yes, you could go ahead, and there's no harm giving somebody 80 of atorvastatin or 40 of Crestor or whatever we have available. People ongoing chest pain, reach out to cardiology. People that are not responding to medical therapy, those are the triggers for emergent or urgent cardiology consultation. Trust me, once you see somebody who's having an MI, you'll never forget that face, that doom, and the cold sweats, and fear on somebody's face. It's all it takes is a couple of those encounters, and if your EKG is normal, but somebody's sitting in front of you and it smells like an MI, it looks like an MI, it's an MI, and it's probably something. If they're not doing well, don't hesitate, activate. We want to be called for those patients.
I love that expression. Don't hesitate, activate. I think this is really important in that group of patients, exactly as you described. They look like an MI, they smell like an MI, they have clear cardiac chest pain. The ECG is not diagnostic of the criteria that makes us activate the cath lab, but the AHA really every set of guidelines has been very clear. If you have a patient who has cardiac type chest pain and they are refractory to your medical management, even in the absence of ST elevations on the ECG, you should be activating the catheterization lab for them. You should be getting in touch with a cardiologist. So I think that's really important. And the statin issue is also really important. With long-term statins for high cholesterol has a very marginal benefit, but this is very different. This anti-inflammatory effect of the loading of a statin when you have a patient with ACS is profound. It's a really important intervention for us to be doing for those patients in the immediate. So those are some things that I think sometimes fall by the wayside, but they really need to be part of our focus in taking care of these patients.
Agree. Again, I don't want to, you remember, for those patients, we don't want to delay also transit to the cath lab. Let's say if it's going to take you 20 minutes to a half hour to get certain medication, we don't want to keep the patient in the emergency room. But if they're there and they're more or less stable and they're going to be going for an invasive procedure or whatever, they're going to be admitted to CCU, what you do in emergency room, the sooner you start the therapy, the better they do.
Let's talk about a couple of specific cases, Ruben, because I find that's really helpful to frame people's minds here. Let's say that I've got a patient who's about 50. They're a diabetic. They've had stents in the past. They've got a concerning ACS or unstable angina type of story. They have some ECG changes, but not the ST elevations that would have made us set off for the cath lab right away. And in general, we're going to give this patient aspirin. We've talked about that. We're going to give him a nitro. We're going to get a troponin. In that patient, should I be contacting cardiology right away? Should I be waiting for the troponin? And if we want to, we can add to that the ECG changes here are again, not a STEMI equivalent, but there's some clear ST depressions or there's some clear new T-wave inversions. Should I get my consult on board right away, or can I kind of wait until I get a little bit more information with a troponin, et cetera?
There's nothing wrong with calling in an early consult. I mean, obviously, the fellow, let's say if it's off hours, the fellow is here by himself. He's not going to be able, especially if you tell him patient is stable, he's not going to be able to come down and see the patient right away. So you start with your medical therapy. You place a call, you start stabilizing the patient, given what we discussed, and then you reevaluate, give him 10, 15 minutes and see how things are. If patient settles down, then it's not as an emergent consult as someone, again, who's in active pain despite what your initial trial of medical therapy in emergency.
All right, so that's great. So it's fine to get them involved. Don't expect necessarily that they're going to be at bedside in 2 minutes if you're telling them about a stable patient, but get them involved early so that you can continue to have that discussion. And if something changes in that patient's presentation, now it's a lot easier to reconsult and say, hey, remember that patient I called you about 20 minutes ago? I got some updated information. The patient's blood pressure is a little softer. I repeated the ECG and there's dynamic changes. I'm more worried about this patient. I think it really helps to set us up for success there.
Correct.
All right, let's say that we've got a similar patient. We give them the aspirin. We might even start heparin. We give nitro and their symptoms improve. The ECG changes resolve, and we get a troponin back, and either it's negative or it's in the non-specific zone. Should I just admit that patient to telemetry, or if I haven't gotten cardiology involved, is this the time to get them involved on that patient?
This is a high-risk patient, because this is someone who has high pretest probability and they come in with symptoms and dynamic EKG changes. If they're stable, they obviously going to get admitted. But again, a cardiology call here is appropriate because, again, we want to employ an early invasive strategy with some of these patients. We want to be aware of them. We want to be able to see them. We want to be able to, with appropriate care, again, nobody doubts anymore with the early invasive strategy. You help these people, you improve their morbidity and mortality. So we want to know about these patients.
And I think this is really important because sometimes people are like, oh, well, they had ECG changes, now they're gone and the patient's comfortable. I don't need to bother my cardiologist now. And these are exactly the cases where we do need to bother our cardiologist. And we really shouldn't think about it as bothering, but this is where we should get our cardiology colleagues involved so that they can act early and decide what the best plan is for that patient.
Agreed.
Final patient to discuss, and we mentioned a little bit about this earlier, but let's just be very explicit about this. We've got the same patient, 50 years old, a concerning story for ACS, ECG changes. We give him the aspirin, we give the nitro. The patient continues to have the same chest pain. We repeat the ECG, and there's no real dynamic changes. It's about the same as it was before. We get our troponin back. Again, it's negative or maybe mildly positive. Should we be getting cards on board for this patient right away, even though we really haven't had those dynamic changes and we haven't had a positive or a markedly positive troponin?
So patient presentation and clinical scenario is very important. If you believe someone is having cardiac pain and your EKG is not dynamic or there's no changes, your troponin is marginal, but you see someone who's uncomfortable or who's having active cardiac pain, your cardiologist should be involved in those cases.
Fantastic. And I know we mentioned that before, but I think it is really important to be explicit about this. Ruben, before we wrap up, anything else that you want to leave the listeners with that they should be thinking about when they see these patients?
So as far as the emergency room management, bedside echo is very important. And again, if this is a patient, let's say it's off hours, you activated the team, it takes on average about 30 minutes for the cath lab to get the room ready to bring the patient up. Bedside echo is great, vast amount of information. If you see wall motion, if you see valvular disease, some of the late presentations, you'll pick up CVMR, or you'll pick up an ASD, you'll pick up VSD, you'll pick up certain things that are there that will help us manage the patient upstairs. Medical therapy, I cannot stress enough. A STEMI patient should not be a phone call to the cath lab, admit the patient, be aggressive with antiplatelets, be aggressive if you know there's going to be, a delay in getting the patient upstairs. We had a couple of instances where we had a STEMI in the lab and there was another STEMI was in the emergency room. It's only one team of ours, and, sometimes those patients will be delayed. So be aggressive with medical therapy, nitroglycerin, IV heparin, dual antiplatelets. If someone is in a lot of pain, morphine, pain medications and all that stuff, ABCs of what you guys do on a regular basis, those things are very, very important.
A lot of those core management pieces, I think we, again, lose focus on. We focus on the advanced therapies, but we need to make sure we do the basics well. And I love the shout out to Echo, because I've had a couple of cases where it sure looked like a STEMI, and then you drop the ultrasound probe on the patient, you're like, that's a massive effusion. This patient has tamponade, and it markedly changes the intervention that's going to be brought for that patient. So, not every ST elevation is from ACS, and we have to remember that. And Echo gives us a lot of information that we can use, and it gives it to us very quickly. Ruben, thanks so much for doing this with us. I think there's so much knowledge that you've imparted to us, that you've given, that can really improve the way we take care of these patients. And there's kind of 5 things that I take away that I think everyone has to remember. We didn't focus on STEMIs, but when we are talking about those STEMI patients, make sure to dual antiplatelet load that patient. Depending on where you work is going to tell which of these medications you're going to be giving, whether it is clopidogrel or ticagrelor, but it is important for us to get those medications on board. In the non-STEMI patients, get your cardiology colleagues involved early to guide management, not just the dual antiplatelet therapy, but also when this patient should be getting ready to go to the catheterization lab, what else should be done in the meantime. The medical therapy that we do for patients is extremely important. The aspirin, the nitro, making sure that the patient has good pain relief, making sure that they have dual antiplatelet therapy when it is indicated. Get your POCUS out, do that POCUS in the ED, even on the patients that are going to the cath lab immediately with a STEMI. If it's not immediate, there's always time to drop that probe on the chest and get a little bit of information. And then finally, trust your instincts. The clinical presentation trumps all data. If you are worried about the patient in front of you, then you probably should be worried, and that's a place to get your colleagues involved early. Call the cardiologist, get them on board, and let them help you to manage that patient the most effective way, even if the ECG isn't showing you STEMI, even if the ECG isn't clearly showing ischemic changes. If you're worried about the patient, get your cardiology colleagues involved early. Ruben, thanks so much again, and we can't wait to have you back on the podcast. That's all for the Rebel Core Content Podcast this week. We'll be back in another 2 weeks on our cast. And in the meantime, don't forget to pop on over to the site and check out all the great posts from our faculty. And until next time, stay safe.